Today I will be presenting on the disease rheumatoid arthritis. Rheumatoid arthritis is an autoimmune and inflammatory disease. Autoimmune disorders occur when the immune system attacks the healthy cells in the body, causing inflammation in the affected regions. RA commonly affects the joints, specifically the hands, wrists, and knees. The lining of the tissue in the joint area becomes inflamed in more than one region, damaging the joint tissues. This damage to the tissue leads to chronic pain, lack of balance, and deformities. Some symptoms patients with RA experience include joint pain, tenderness, swelling, stiffness, especially in the morning, fatigue, and for some, fevers. Having symptoms is considered a flare-up. Flare-ups can have lingering symptoms that last anywhere from days to months. Small joints in the wrist, hands, or feet tend to be the first areas affected by the disease. Inflammation of the joints are commonly found in the synovial membranes and fluid of the peripheral joints. This causes damage to the articular cartilage and bones of those affected joints. Inflammation of the cartilage deforms the joints, causing erosion of the bone, and can lead to the fusion of the joints, which is seen on the photo of the hand on the right-hand side. And this would be the body's natural response to protect itself from frequent irritation. Patients diagnosed with RA can find it harder to exercise due to that joint pain and experience weight gain. Overweight patients with RA have a higher chance of developing high cholesterol, diabetes, heart disease, and high blood pressure. Organs, systems, and tissues affected by RA include the eyes. The eyes may experience dryness, pain, inflammation, redness, sensitivity to light, and trouble seeing properly. The mouth may suffer from dryness, gum inflammation, irritation, or infection. Small lumps under the skin over bony areas can arise and are defined as rheumatoid nodules. Affected lungs show inflammation and scarring that can cause shortness of breath and lead to lung diseases. The blood vessels can become inflamed, damaging the skin, nerves, and other organs. The blood has a decrease in the number of red blood cells, and inflammation in the heart damages the heart muscle and surrounding regions. Regions of the body that are affected by RA include the synovium, cartilage, and bone. In their normal state, the synovium is typically thin, fragile lining that is about 1 to 3 cells thick. It is a source of nutrients for cartilage and produces hyaluronic acid, collagen, and fibronectin. The synovial cavity in its normal state is highly viscous with only a few cells that are primarily neutrophils. The subintimal area is highly vascular as well with only a few cells. The cartilage is a resilient tissue that has the ability to absorb impact and stress, and the bone consists of type 1 collagen tissues and cells. The homeostasis of mitochondria plays an important role in RA. Mitochondria are famously known as the organelles that are the powerhouse of eukaryotic cells by their ability to produce ATP energy. Their stability is shown in numbers, morphology, and spatial structure through the homeostasis of the biological processes, including biogenesis, fission, fusion, and autophagy. They're involved in signal transduction, reduction, oxidation, cell cycle regulation, and apoptosis. Imbalances in the homeostatic environment of mitochondrial biological processes affects the energy metabolism in the immune cells, proliferation of synovial cells, apoptosis, and inflammatory signaling, which are all involved in the development of the disease. The figure on the right-hand side shows the mitochondrial homeostatic biological processes, including biogenesis, mitochondrial dynamics, and mitochondrial autophagy and includes the development of rheumatoid arthritis. The key protein for regulating biogenesis is PGC1, and the two key proteins involved in the regulation of mitochondrial division are DRP1 and DNM1L. In a disease state, METTL3 and YTHDF regulate the PGC1 mRNA and activate the PGC1 NRF1 TFAM pathway, causing mitochondrial biogenesis to be inhibited and promoting synovial inflammation. In rheumatoid arthritis, DRP1 and DNM1L bind to MFF and FISL1 and localizes to the outer mitochondrial membrane, where they trigger mitochondrial fission and secrete inflammatory substances through GTP hydrolase. In a disease state, the synovial lining becomes greatly hypertrophied. So earlier it was thin, and now it is about 8 to 10 cells thick. The hypertrophied synovium is known as pannus, and it invades and erodes contiguous cartilage and bone. The subintimal area becomes heavily infiltrated with the inflammatory helper T cells and B lymphocytes, macrophages, mast cells, and mononuclear cells. The heavily infiltrated subintimal area has new blood vessel growth known as angiogenesis. The synovial cavity becomes highly inflammatory with large collections of fluid with high protein content infiltrating the plasma. The cartilage becomes impaired in its integrity, resilience, and water content. Chondrocyte catabolic pathways and matrix destruction are increased, and new cartilage formation is inhibited by the pro-inflammatory cytokines IL-1 and TNF. The bone has deteriorated by the osteoclast activity. On the right-hand side, disruption to the homeostasis of mitochondria is shown. Damage occurs through the downregulation of several mitochondrial proteins, increased mtDNA copy numbers, and low expression of the mitochondrial membrane potential. Demand for mitochondrial electron transfer energy is increased, causing electron leakage and reduced oxygen molecules to superoxide anions to produce reactive oxygen species, which promotes inflammation. The structure, number, and function of mitochondria is altered. Symptoms patients experience with RA is caused by damage to the joints that start at the synovial membrane. The pannus, that is the hypertrophied synovium, is now rich in osteoclasts that destroys the bone. Synoviocytes and chondrocytes secrete enzymes that degrade cartilage. CD4 T cells amplify the immune response, and cytokine release manifests synovial inflammation and develops systemic effects. The hypothalamic pituitary adrenal axis is affected by that release of cytokines and synovial inflammation that causes fatigue and depression. Rheumatoid arthritis is known as the cancer that never dies due to its incurability and has a disability rate of 61.3%. Diagnosis methods include getting a medical history, physical exams, imaging, including x-rays and ultrasounds. Lab tests are also done, specifically the CCP assay. That is the major test for RA and is more specific than the test for rheumatoid factor, known as RF. There are AI models available for the diagnosis of RA, although more research is required to conclude that AI has enough precision and dependability, as there are ethical issues and technological issues present. Through deep learning, imaging data is analyzed by X-rays, magnetic resonance imaging, MRI, or computer tomography, CTs, and detect the changes early on that mark the development of RA. Other models include naive Bayes, convolutional neural network, CNN, logistic regression, and the support vector machine, SVMs. The medications available to treat rheumatoid arthritis include NSAIDs for pain and inflammation, DMARDs that are conventional synthetic medication used to slow the progression of RA. Methotrexate is primarily the first prescribed, although other DMARDs are used for treatment include leflunomide, hydrochloroquine, and sulfasalazine. Biologics are genetically engineered proteins that are used to target specific parts of the body's immune system that are responsible for inflammation. This form of medication is used when the body is unresponsive to DMARDs and is administered through intramuscular injection or intravenously. JAK inhibitors work by blocking the inflammatory enzymes JAK1, JAK2, JAK3, and tyrosine kinase 2, and include tofacitinib, baricitinib, and upadacitinib. These are administered orally. Analgesics such as acetaminophen can be taken to reduce pain when it is not possible to take an NSAID, and oral corticosteroids are given while waiting for slower acting medications such as DMARDs to work and are used as an anti-inflammatory. Medications are critical for patients suffering from rheumatoid arthritis and serve as the primary source of treatment. Joint surgery is considered when the joints are needed to be repaired to improve their function, with hip and knee surgeries being the most common. For pain management, there are options such as hot and cold treatments, rest, massage, topicals, and creams, and acupuncture. It is recommended that patients have physical therapy, quit smoking, and have some dietary changes. People that are more likely to develop RA would be adults in their 60s, although it can occur at any age. Women are about 2 to 3 times more likely to develop RA when in comparison to men. People that smoke or women who have had live births, obesity, genetics, and inherited traits, and early life exposures or experiences, such as adults who had mothers who smoked during their childhood development or who had parents that had a lower income. For demographics, the incidence in the US is about 70 per 100,000 annually, and globally it is about 18 million people. The prevalence in the US is about 0.6 to 1% of the adult population. Globally, that is 1 to 2% of the population. The survival rate was taken from a population-based study that occurred between 1998 and 2009. The 5-year survival rate was about 80% for patients with RA and 88% for the control group. The 12-year rate was 61% for patients with RA and 74% for the control group. For mortality, the risk in patients with RA is about 1.5 times greater than the general population. The mortality risk is higher in people with RA due to the cardiovascular diseases, respiratory diseases, systemic inflammation, and infections associated with the disease. The risk of infections with RA patients are likely to be caused by the immune function or effects of immunosuppressive therapy. And these are my references used for this PowerPoint. Thank you.